asked me to give this talk when we met at the September at the Parkinson's lecture, excuse me. Now, the way that David actually gave me the title was he wanted me to speak about the Parkinson's Excellence Network first, and I've sort of crowbarred in the research update. So I've actually put the talk in that order: Excellence Network and then the research update. Although in some ways it would almost be better flipped around, but I didn't want to upset David's order. So that's what we're going to go for. And do you want me to give a sort of a quick break in the middle between the Excellence Network discussion and then the research? Because we can do that if that would be helpful. It's about 20 minutes each. No. So just let me know.
No, Gordon, just carry on and do it all in one go. It makes it easier for the question and answers.
Great. So are you happy if I share my screen now with my slides?
Yes, I am.
So hopefully you should all be able to see my slides now.
Yep, we can see them.
Great. So what I'll do is I'll spend the first half of the talk just talking a little bit about the Excellence Network. And then, as I say, I'll spend the second half of the talk talking about sort of this clinical research studies and so on. So as David said, the Excellence Network was established in 2015 by Parkinson's UK. And the idea being as a sort of a mechanism really to bring together health professionals actually to develop and form better health and sort of clinical services for people affected by Parkinson's disease. It's sort of disseminated across the country, and each area has its own sort of local group with sort of clinical leads and support from Parkinson's UK. So of course in Scotland, as you all probably know, we get excellent support from Mary Elmers principally, but also sort of James Jopling and Tanith as well. The Excellence Network has recently been rebooted and overhauled with the appointment, of Rowan Wathis as the Associate Director for the Excellence Network and Service Improvements. And this is a sort of the infographic that I think they've sort of put together to explain how it works. But I think from my perspective, what I think has been more helpful is I've lost the slide. I'm sorry, I've lost the slide. I had a slide which basically showed the different strands of the network, which is maybe jumped. Hold on. No, I'm sorry, I've somehow managed to delete my critical slide. So anyway, the Parkinson's Excellence Network, basically, it works slightly differently across the 4 nations. But the idea being is that it uses, it's a way of sort of driving service improvement. Of course, to do that, you need to understand what services are occurring, how are services configured in different parts of the country, and how are they doing? How are they staffed? What medical staff are there, nursing staff, physiotherapy, occupational therapy, speech and language therapy staff are there available? And where do they sit, be it in hospitals and primary care? And also, how are those services able to perform? How many numbers of staff are there per head of population? I guess partly, and how do they operate in terms of their clinics? The next part of the network, I suppose, is to make sure that those staff are all supported in what they do and have access to networking and education and training modules so that they are able then to try and deliver the best care as possible to people with Parkinson's disease. So the Parkinson's Excellence Network also provides quite a lot of learning resources, and it's not just for those of us who work, I suppose, more in secondary care settings. They also provide resources for people in care homes and in communities, and a lot of the training material and learning modules is very much designed around people who don't necessarily have Parkinson's disease as their main interest, but will encounter people with Parkinson's, perhaps not necessarily part of their everyday work, but certainly once or twice a week. And by that, I mean, as I say, people in care homes, GPs, district nurses, that sort of thing. And there's lots of information there available. The other thing, of course, is that the Parkinson's Excellence Network is trying to get more involved with is developing sort of service innovation, sorry about that, service innovation, and how we can, I'm sorry, how we can develop services that way. And that's sort of very much bringing through R&D developments into service regular service provision. And that's, using things like, apps, devices, PKG, that sort of thing. How can you make your service better and more efficient? And then finally, I think, and perhaps most excitingly in some ways, is there's money available through service improvement grants. And that's usually actually to appoint staff or bits of staff, I suppose, buying a few hours of a physiotherapist, buying a few hours of an occupational therapist, a speech and language therapist. And it's how you then use those people to try and support your Parkinson's teams. And we'll come on to that in the next slide. So really, there's quite a lot available. And I think because there's so much available, it's quite easy to get lost in what there is. And one of the things I think that Parkinson's UK recognised a year or two ago was that perhaps the need to sort of distill down what exactly Parkinson's, the Excellence Network should be doing and how it needs to prioritise itself. And they've basically set themselves these 4 Excellence Network programmes. And these are across the UK. And I'll speak about each one of these in turn. But first of all, let's look at the Parkinson's nurse workforce. I think we need to be honest that the Parkinson's nurse workforce are all getting older. There was a huge investment in Parkinson's nurses about 10, 12 years ago when Parkinson's UK primed a lot of posts, but they aren't now all getting older and they're looking to cut their hours. And again, same with integrated multidisciplinary care. We really want, and we've all spoken, we've all heard, and Julie gave that brilliant presentation a few months ago, really looking at how important it is to have a specialist or knowledgeable multidisciplinary team sort of surrounding that person with Parkinson's and how we support them. You probably heard, and what's sort of gaining a bit more momentum now is the bone health module or program, which is being led by Donald Grosset. Now, Donald, of course, was the previous clinical director of the network, and he's sort of taken on the service improvement lead for the network. And he's really sort of recognised trying to drive this improvement in bone health, and that's osteoporosis screening and implementation of primary and secondary prevention medications to try and reduce fracture risk. And then finally, there's get it on time or time critical medications. And that's being re-looked at now. I'm probably going to give a bit more focus on bone health and get it on time over the next few minutes. So really, in terms of looking at the workforce, you will all have recognised that, the Parkinson's nurse, and I'm very conscious that I'm being recorded here, workforce is getting a bit older, and many of them are looking to cut their hours or indeed retire. And there are multiple reasons for that. Working through the pandemic has been hard going for a lot of people. Many of the nurses were redeployed at times. There's the issue around pensions, and then there's also just the issue of just people need a break. So it's really important that we continue to develop younger nurses coming up through the system with expertise and motivation to enhance service improvement, but also succession planning. And we locally have, I'm going to be honest, we've been struggling actually to find people to take these posts, because there are practical considerations. It is a different style of working for nurses coming into posts. You have to be quite specialist and knowledgeable, and these posts don't come up very often. So you actually need someone, the right person at the right time. So we're certainly looking to recruit 2 Band 6 Parkinson's nurse specialists currently, and that advertising process has just come to a close. And that's a similar place across the country. A lot of the kind of the senior, I suppose, leading Parkinson's nurses of Scotland are all now retiring. Currently, our caseload in Lothian is probably about 1 to 5 to 600 people with Parkinson's disease. Parkinson's UK are stating they'd like something around 1 in 300, so clearly we've got a long way to go. And of course, remember, the Parkinson's nurses aren't just looking after people with Parkinson's, they're also looking after people with multiple system atrophy, progressive supranuclear palsy, and various other disorders as well. But what we really want to do is to get more people into post and have a sort of clearer entry strategy for that. And I think one of the ways I'm hoping we'll be able to do that is perhaps having more, probably sort of Band 5, less than full-time posts, perhaps supporting some of the patients in hospital with Parkinson's disease, perhaps Parkinson's disease liaison nurses into care homes. So I think what we need to do is get a little bit smarter and recognise the changing demographic of patients, but also of nurses, as to how we configure these newer posts. I don't think I need to really labour the point too much to this group about the importance of better and multidisciplinary care being offered. And really, it's never a nut I don't think we've ever properly cracked. And that's just basically for multiple practical issues. What we really want to do is obviously have, when the person with Parkinson's is diagnosed, you want really to have them seen by, as well as the doctor and the nurse, a physiotherapist, get into good exercise habits. We all heard Julie Jones's talk back in September, and I think that was pretty convincing, or it certainly convinced me, of the importance of that early physiotherapy assessment and intervention at the beginning. But then how do we maintain those habits all the way through? And of course, a lot of that is not fully specialist, but it's specialist enough that you need people to have an interest, and you need people to be available to do that. And it's the same with occupational therapy, although perhaps we all think of occupational therapy as being more relevant later on in someone's condition. But actually, if you think earlier in the disease for younger people, they may need adjustments at work, they may need adjustments around the house to sort of help them work as well. So we need to sort of have that sort of specialist knowledge. And there are various different AHP programs in place currently to support that, not only through the Parkinson's Excellence Network, but through the College of Physiotherapists and also the College of Occupational Therapists. And again, we all know that Bas Bloom has done a huge amount of work pushing that agenda forward. And this is, I think, where some of that comes from, the Parkinson's Net model from Holland. The accelerator sites, well, 5 of those are actually sitting in England currently, and then there's one in Perth and Kinross currently, and that's Lorna. That's quite an intense program, and I don't know much about that, I'm afraid. Excuse me. But one of the things, as I say, that we've also found in the pandemic that in multidisciplinary care has been much more of a challenge, again with retirements, interested staff, disruptions to way of working, and we're almost at the stage now where sort of the dust is settling again, and we can start to rebuild services and rebuild a lot of the sort of connections actually, and the sort of relationships that are so critical to all of these services working together and working smoothly. I think in Lothian, the other challenge that we have, of course, is we've got different localities. We've got West Lothian, City of Edinburgh, East Lothian, and Mid Lothian. We've also got different age groups, and it's how you configure, I suppose, the right service close-ish to somebody's home is not without its challenges. So the third of the four programs that the Excellence Network is focusing on currently is the Get It On Time. Now that, of course, has been on the go for about 15 to 20 years, one way or the other. And I think it'd be fair to say it's never been fully cracked. Certainly locally, it's we audit regularly the Parkinson's admissions to the hospital, look at medication administration. But certainly locally for us, it's the self-administration policy. It is a challenge. I think as well, from a national perspective, it's been difficult to have a kind of a one-size-fits-all approach to this. Of course, all hospitals have got their own different prescribing systems. We have just in the last, 18 months, 2 years, I suppose now, moved on to an electronic prescribing system, which doesn't actually make prescribing for someone with Parkinson's any easier, but it certainly does make the audit process easier. But that's not much use for the person at the time. Johnny Aitchison, who is an emergency medicine consultant, actually, I think in England, he's sort of leading on this sort of campaign for Parkinson's UK, and has been going around trying to get health boards and chief executives of NHS Foundation trusts to sort of pledge support to this. I don't think Lothian has signed up yet, and that's very much a work in progress. Some areas in Scotland are doing better at this actually. Grampian have done a huge amount of work and have sort of come up with they've got a nurse supporting this, and they've got a pharmacist as well, and that's certainly a model that we're looking to replicate locally. And of course, the problem with taking medication on time is it actually relates to a bigger problem, in my opinion, of how we look after people with Parkinson's in hospital. Because usually people with Parkinson's, when you do come into hospital, it's either for an operation completely unrelated to Parkinson's, so bladder surgery, prostate surgery, colorectal surgery, and that has its own challenges around operation, anaesthetic timing, or it's if someone is coming as an unscheduled admission, for example, if they've fallen and broken a hip, again, there are different challenges there. Or if someone has come in with pneumonia or a urine infection, again, there are different challenges there. And it's how we, I suppose, have a comprehensive, I suppose, one-size-fits-all approach to recognizing that everyone is completely different. Everyone's Parkinson's is different, everyone's situation is different. So that, I think, probably is the sort of competing tensions. And it really, in my opinion, shows why it's so important that we actually have that Parkinson's nurse workforce available who are able to go in and monitor the patients when they are in hospital and provide advice and support to the clinical teams. And certainly our nurses currently are too stretched to be able to do that to the level that we would like. And I think that's one of the reasons why Grampian have done so well, is that they've appointed a band 5 who really very much focuses on this. And I'm quite envious of that. So this, as I say, is a campaign that's been given a reboot at the moment. And then this was the final programme is the Bone Health Project. And this has been led by Donald Grosset. And this really sort of came out from the past few national audits, which really found that services are not quite so good as we'd thought at first of all, performing falls assessments, but also then thinking about osteoporosis in people with Parkinson's disease. And what's sort of become clear is actually that, normally if you look at the sort of usual population of people who fall and break their hip, it's usually, it's about 2/3, 2/3 women to 1/3 men. But actually in Parkinson's disease, there's more men are actually carrying the burden of those fractures. So it's a slightly different demographic in Parkinson's disease. And we know that if you can improve someone's bone mineral density, then you can reduce their fracture, reduce their risk of either a hip fracture, wrist fracture, humerus fracture, or even a vertebral fracture. Of course, vertebral fractures are associated with pain. And we know that hip fractures, they are pretty devastating injuries to have. And at least a quarter of people are usually often dead within the succeeding 12 months. These are not people with Parkinson's disease, by the way. These are just people who fractured their hip. But also people are not always able to live independently. So if we're able to try and reduce the number of people fracturing, I think that's well worth doing. And it's something that's very amenable to measuring and implementing treatments. So what we've been doing in Scotland is we participated in, there was a sort of a bone health pilot which reported on this programme, which is, as I say, Donald is leading on. And the sort of next stage of that is coming in, I suppose, this coming year. And we've just started as part of the mini pilot, is trying to look in a more structured way, the way when people come through the clinic, looking at the risk factors for osteoporosis and recording what's called their FRAX score. And that sort of takes into account people's age, gender, whether they've broken a hip, their maternal, paternal history of hip fracture, what medications they take, and whether they smoke or drink. And then that sort of gives us a guide as to how we should be advising them. Just do more weight-bearing exercise, stop smoking, stop drinking, or do you add in calcium, vitamin D to your diet, or should we be referring someone for a bone mineral density scan? In Lothian, that's done at the Western General Hospital. And then that will then give us an idea as to whether or not we should be advising that people start on bisphosphonate medication, principally as osteoporosis primary or secondary prevention. And the hope being is that that will then have a knock-on effect. Now, these medications, the bisphosphonates, alendronic acid, risedronate, and so on, they're not without side effects. So they do, we can't just say, oh, you've got osteoporosis, there's the tablet. They do require counselling, compliance checks, And that, of course, will need to be done in primary care as well as in secondary care. So, trying to implement this does actually take time out of the clinic in terms of what you're doing. So it almost means, you're going to have to then spend less time talking about something else, potentially with someone in clinic, if you're going to sort of focus on this. And of course, many people, you probably only need to do these assessments once every 4 or 5 years, practically, because people are not going to change their alcohol or their smoking habits significantly in that period of time. They're certainly not going to change their gender. They're not going to get any younger. It's more of other things. They're not going to change generally their parental history of a fracture. But some of their medications might change. They may lose weight. So probably every sort of 4 or 5 years is probably at the right time for us to be doing this. But again, it's how we record and how we think about it. Again, one of the rate limiting factors we've got locally is the access to bone mineral density scanning, and that has often taken quite a long time. When I started as a consultant in 2014, it took about 9 to 12 months to get a DEXA scan, which is quite a long time. And of course, in that time, a lot can happen. That seems to reduce now to about 3 to 4 months. So that's really, really good. And that means we can have some much more meaningful conversations with people. Again, these medications, if you are going to start someone on a bisphosphonate, you need to be taking it at least a year, week in, week out, for it to have any benefit. And then for you to derive this at the ongoing benefit, you need to be on it then for another sort of 5 to 10 years. So it's not for everyone. And if you think, if someone already has swallowing problems, that might not be entirely straightforward, and you might need to look at an intravenous option instead. So there's a lot to think about. So although it sounds superficially very attractive and it is important, it does require quite a lot of sort of thinking behind the scenes as to how we implement that in services. And of course, I'm a geriatrician. This is fairly straightforward for myself in terms of how we approach these conversations and how we sort of investigate and manage people. For the Parkinson's nurses and the neurologists, it's not quite so straightforward, and I can understand that. And that's just the results of the improvement project. And so the first wave that was done, and we in Edinburgh didn't participate in this, but really it just shows that the number of people accessing bone or put onto bone treatments such as bisphosphonates or calcium vitamin D actually sort of rose. And the idea being that it reduced fracture frequency. Most of the fractures will have been wrist or vertebra, statistically, in terms of how these medications work. And what they're doing is extrapolating trial results there. There is available a YouTube video on Parkinson's if you want to have a look later on. I've not embedded the link into this because I didn't want to crash the presentation. I'm always worried about having videos and presentations, which is why my slides are always really quite boring and dull, because I just never want to be that person. So I think I've been involved now as a sort of South East Scotland League Parkinson's for about 2.5 years. I took over from Conor Maguire just after the onset of the pandemic. It's a really good way, actually, as a professional, it's a really good way to keep up with colleagues, learn what other areas are doing. It's very much about sort of, tips and tricks and how do you get around this problem or get around that problem. But what the Excellence Network are really keen to do is to get more people with Parkinson's involved. I think I really just encourage you to go on the Parkinson's UK website and have a look, because there's this multiple different strands of involvement that you can sign up to. I've listed some of them there, but I say, you're all very internet savvy, you're all involved with a branch. Just go on and have a look if that's something that would interest you. Do you want me to take any questions now about that, David, or do you want me just to keep going?
I think it's much easier if you just keep going, please, Gordon.
Okay, I'm just going to have a cough.
Carry on.
Sorry about that. So, when I came and spoke to the branch, as I say, in December 2020, not December, sorry, January 2020, always looking very rosy and exciting. And as I say, then the world kind of, well, stopped, didn't it? So what I wanted to do was just spend the final sort of 10 minutes of this talk just going through where we're at with some of the local research projects for Parkinson's. But again, I want to set that very much in the context of the sort of delays we've had as a consequence of the pandemic, and that has been around, obviously, the clinical trials unit at the Western was repurposed for cancer trials in that time and vaccine trials, as the cancer unit had to get repurposed. A lot of the R&D department had to sort of work from home and were repurposed. Again, much of the R&D infrastructure was put towards COVID trials, and of course many of those were really successful, like the recovery trial, for example, the vaccine trials. And we also felt that it really wasn't appropriate to be exposing people with Parkinson's or other conditions, for that matter, to environments where they would be potentially catching COVID. So it has been a significant setback, actually. And many of us, while I was never repurposed, shall we say, my core job remained pretty much the same. It did mean that I had less time to be devoting to this. But certainly, the research nurses, they were slightly repurposed. The Parkinson's nurses were redeployed for times. So a lot of this, we've definitely lost a few years. However, and of course, as part of that, a lot of the studies had to have amendments put in to allow remote working and video conferencing and so on, and that all took longer to get through the R&D departments, because the R&D departments were all focused on COVID studies. So everything has just taken longer, but we're getting there. Sorry about that. So just to give you, I suppose, to sort of set things into sort of context, I think our sort of general strategy, I hope, for Parkinson's sort of clinical research in Edinburgh and Lothian is very much sort of, I guess, focused with the person with Parkinson's at the middle of it. And then we have the supporting structures around to make the research happen. And of course, for you, most of your input is with your clinician in your NHS clinic. And I've sort of given the example there, the Anne Rowling clinic, but I'm sure you all know that that could be at the Western General, St John's, East Lothian Community Hospital, Liberton Hospital, Mid Lothian, Leith. And that is really the main point of contact for people with their clinicians. And what we really want is for the clinicians, the nurses and the doctors you're seeing, to be aware of the current research studies. We want you to be aware of the current research studies and to be able to have that bit of a conversation if you all think it's relevant to you. And what we're doing is spending quite a lot of time, I hope, making sure that my local colleagues understand what studies are running currently. Because of course it's not, they can't, in your short clinic time, you can't spend a huge amount of time on this, but it's more just about raising general awareness. Locally, our studies are supported, and effectively my sort of research nurses and coordinators or clinical studies officers, as they're known, who manage the projects, are from the Neuroprogressive and Dementia Research Network. And that was previously the Scottish Dementia Research Network, and that's funded by the Chief Scientist Office, the NHS Research Scotland. And you've probably met Jackie, Maria, Kirsty, and we've got a new member of the team now, Connor, and then Bernie's back as well. So we've got and they all work less than full time, but they are a really experienced group of clinical studies officers. And four of them have got nursing backgrounds. Connor's got a psychology background, and they live and breathe clinical trials. And they know all the people in the R&D office, the CRF, they've got excellent relationships with the sponsor sites and so on, and they really just manage the sort of nitty-gritty of getting the trials off the ground. The Neuroprogressive and Dementia, or NDN, each health board has got its own team, really to focus to delivering studies such as this. A few years ago, this NDN was repurposed slightly away from dementia to sort of broaden its remit. I'll come back to that in a minute, actually. The Edinburgh Clinical Research Facility, some of you will know, and David, obviously you led the tour there a few years ago, that is at the Western General Hospital, and that is where we perform most of our interventional clinical trials currently. And the rationale for that is they know what they're doing. It's an accredited clinical trials unit. The research nurses there are absolutely brilliant. They're very, very careful. I see a few of you on this call who have been part of the studies. They're very kind, they're very caring. They also, they keep us right, and it's so important to maintain the integrity of studies, to have people who are just really, really, really careful and absolutely focused on the minutiae of things, and they do not let things slip. So if any of you are involved in the trial and you think you're being nagged slightly or told off, it's all for a very good reason, because we need to preserve not only the integrity of the trial, but because that then ensures the safety of the participant, and we cannot have any safety issues. Well, first of all, for the participant, but also we can't have anything that would sort of compromise the confidence or the reputation of the unit, because that has knock-on consequences for us. The R&D office is situated at the QMRI, the Queen's Medical Research Institute at the Royal Infirmary, and that's a sort of a joint academic NHS research office between NHS Lothian and the university, and that's where all the sort of approvals and the contracts and so on go through. And they're actually a very, very helpful team. So it actually takes quite a lot to get a clinical trial running smoothly. Excuse me. So I wanted just to spend a minute or two speaking about the Neuroprogressive and Dementia Research Network. This is really the sort of the main team that support Parkinson's clinical trials locally. They're funded, as I say, by the Chief Scientist Office. Each health board has got clinical studies officers aligned to it. They are part of that health board effectively. We have got 4, all, as I say, experienced research nurses or psychologists. And really their job is to ensure that studies get up and running quickly, all the approvals and so on are met, taking care of a huge amount of administration, not only for the study, but in terms of sort of participant-facing admin as well. We, obviously locally, our main interests are Parkinson's disease. We have done studies for people with dementia with Lewy bodies. Progressive supranuclear palsy and multiple system atrophy are far less common, and really have got a different prognosis and trajectory and are much harder actually to include in clinical research studies, but we are certainly open to it. The team also supports Alzheimer's studies and mild cognitive impairment studies, and we've got 1 or 2 trials running for that as well. Huntington's disease, we support a couple of Huntington's studies. Nationally, motor neuron disease also falls within the remit of the NDN team, but certainly locally, everything is run via the Anne Rowling Clinic and the MND team there. So our local team doesn't have a huge amount of involvement in MND, and in fact not so much in Huntington's either, as there is the established Huntington service. Alzheimer's studies are actually becoming much harder to do now, because of course with the loss of none of the antibody studies have really been convincingly positive, and it's also much harder now to enroll people with early cognitive impairment into these studies because of either age or sort of other factors such as presence of cerebrovascular disease and CT scans. So I suppose what I'm trying to say is that our team really is very much focused on Parkinson's and has by default become a Parkinson's disease research team, which I think is fantastic, and to me it's wonderful. Whereas if we'd gone back 6 or 7 years ago, it was very much an Alzheimer's and dementia team, and the team have done an absolutely brilliant job at sort of just flipping, I suppose, and pivoting into a different field for them. And it's taken, we've done a lot of teaching and training and education, and they've gone on courses, but they've really enjoyed it. And I'm really pleased and really proud. And as I say, I'm only just sorry that the past few years of pandemic has occurred, because we'd obviously, for all the other reasons, but we'd gone into 2020 really excited, really enthusiastic. Everyone had done all their training and was desperate to get going, and then all that was put in pause. So I've told you about the CSOs, other medical staff. We all know David Breen. Tom Russ is an old age psychiatrist. He sort of leads the Alzheimer's and sort of dementia studies. And then Pete Foley is one of the neurologists who's got more of an interest actually in Huntington's disease. What we really, really need to make sort of recruitment to clinical studies easy and straightforward is to be able to get direct access, I suppose, to people with Parkinson's disease, so that when a study comes along, we can recruit them quickly. And I know I've spoken about this before, and I know there is probably a slight feeling of deja vu here, but traditionally the main way you were able to recruit someone with a condition to a clinical trial was you had to wait to see them again in clinic. You then had to cross your fingers that the clinician who was seeing that person in clinic had time and remembered to speak to the study and highlight it to the clinical studies team. And if you're only seeing someone in clinic, maybe 2-3 times a year, once a year perhaps, that's quite a big ask. So although we are still very much encouraging, the nurses and doctors to refer people into studies where possible, what we really want is for people with Parkinson's disease to make use of the disease registers that we now have available, disease research registers that we now have available, so that we can contact people directly and at the time. For those of you that attend the enrolling clinic for your Parkinson's, that's saying either Richard Davenport or David Breen, I would hope that you've all signed up to the Rolling Care Register, and I'll come back to that in a minute. We have also in the past, we've given out leaflets at branch meetings and various events to try and encourage people to sign up to that. Anyone can sign up to that online on the internet. The paper copies, however, have to be done within the enrolling clinic. The other route that we have available is a sort of a newer scheme, which was opened last year, which again is funded and managed through the Neuroprogressive and Dementia Network, so that's the NDN, is permission to contact. And in some ways, at a health board level, that is a sign-up scheme, a disease register that is easier for us to administer, because it doesn't mean that people have to only attend one physical clinical space, i.e. the enrolling clinic. And what we're hoping is that most people with Parkinson's will be on the NHS Research Scotland permission to contact, and some will be on rolling care. And if people are on both, that's absolutely fine. Ultimately, hopefully in the longer term, we'll be able to merge some of these registers together. But health informatics platforms are not straightforward, as I have come to learn. So rolling care, again, I'm assuming that all of you who have attended the enrolling clinic for your Parkinson's clinic are fully aware of this and will have signed up, and I'm hopefully not telling anyone anything new here. So basically, it's a clinical registry that you sort of sign up to the consent form. You say that you're happy to be contacted, you're happy to be involved in the design of studies, and you're happy that your clinical information is used to potentially contact you about studies. Of course, at any point you can say no to anything. So you can sign up to everything and say yes to everything. But on the day if you're contacted, you don't have to say, yes, I want to take part in this, or yes, I'm interested. You can say, thanks, not this time, not a good time for me, or I'm just not interested. And that's absolutely fine. But it's more about having your details registered with that. So say if you attend an enrolling Parkinson's clinic, please make sure, if you're interested, that you're signed up to this. It was initially developed really for people with motor neuron disease and multiple sclerosis. And then what they've done is merge the data sets with the young onset dementia database as well. And then what we've tried to do is we've got people with Parkinson's signed up as well. As I say, anyone living in Scotland can take part if they sort of go and sign up online. But I think these days a lot of people like to see something in paper as well. And in order for that to happen, you actually need to be in the physical clinical space. But you certainly can sign up online. So permission to contact is being sponsored by the NDN, the Neuroprogressive and Dementia Network, and that, as I say, went live last year, and it's taken, say, about 3 or 4 years to develop. It's hosted by the Health Informatics Centre in Dundee, which I think traditionally has been very much the home of healthcare informatics in Scotland. I would really, again, encourage everyone to, if you're offered either by your Parkinson's nurse or clinic, if you're offered one of these sort of trifold leaflets to complete and send back, please do it. We are very, very keen to have on the national register everyone's with Parkinson's, so that we can contact them quickly. about Parkinson's disease studies that come up. What we do is we either send them out to people with their appointment letters, or send them with their clinic letters, or give them to people in clinic, or have them lying around. I am also happy to send out a batch for the next branch get together, and people can just fill it in. It's a sort of stamped and sort of a prepaid trifold leaflet, and I've got one here. Put it away yesterday when I was tidying up. So it looks a little bit like this. And what happens is you sort of fill this back out, cut down here, and then stick it back together, and it just goes in the post, and it goes to Dundee, and that information is all securely held. I am hoping that in 2023 I will get an invite back to an in-person meeting, and I will bring a batch of these along, David, and I will also be able to give you a bit more of an update about some of the research studies that we're going to be talking about, because most of these are actually about to go live in 2023.
Thanks for the
these should all come out on new patient information packs as well. If anyone wants one of these, I can send them out to you as well. So just let me know at the end, and we can post them out to you. So what I thought we'll do is I'm aware that time is getting on, mainly because of my coughing. Excuse me. I'll just quickly go through some of the studies that are either ongoing at the moment or opening, and realistically it'll be next year now. So I think probably the most exciting study that we're doing is the Zenotide PD3 study, and that's the Tom Faulkney study. Excuse me. Sorry, the dangers of a viral child. That's looking at Zenotide, which is a diabetes drug, a GLP-1, excuse me, agonist. And we're given that, so we've got 16 people locally who are participating in that, 200 people recruited nationwide. I think it's actually 196. And certainly that study is ongoing. And what we're really trying to do is to find out if the results from the phase 2 study, the Zenotide part 2 study, where you can see the 3 MDS UPDRS point difference, where that can be hopefully maintained and indeed improved after 2 years. So it's been a really good study to take part in. It's our first proper interventional drug trial for Parkinson's in Lothian. And again, it's been very much supported by the NDN research team and the CRF nurses, and they have done a brilliant job. It's been a really good study to do. It's been a really well run and managed study. The team in London are absolute pros and have got lots of experience. And I know there's a few folks on this call today, excuse me, who are participating, and I hope haven't found it too onerous a process. The recruitment criteria were quite strict, and it's really important that we had to be quite strictly enforce those criteria as well, again to ensure participant safety and the integrity of the study. And it's been really important, and again, nobody has dropped out of the study so far locally, and even nationally there's the number, I think, is fewer than 5, because we really want as many people to sort of start and finish to make sure the results are meaningful. And a lot of that, as I say, has been down to the local teams really working hard and working well, partnering with participants. So hopefully in a year or two, probably a couple of years' time, I'll be able to come back and give you some results on that. Studies that we're hoping to open next year, probably the first of all will be the Chief PD study. And this was a study, of course, I came and spoke to you about in January 2020 and said, yep, we're just about to get the green light for that. We'll be opening that in March. That was almost 3 years now delayed. And this is really a study looking as to whether we can mitigate falls in Parkinson's disease. And the rationale for that is that falls and walking, or walking and falls and sort of control of balance, is as much controlled by acetylcholine as it is dopamine in the brain. And rivastigmine is a cholinesterase inhibitor, similar to donepezil. So these are medications usually used for dementia, but the idea is it increase the amount of available acetylcholine in the brain and try and help people, I suppose, attend to what they're doing slightly better, think about what they're doing, and hopefully give a bit more attention to their walking. And again, this is looking to build on the results of the phase 2 RESPOND study. Again, I will be in more contact with you all about this. In real terms, it's going to be the new year now. Another amendment has just gone through for the study, which is just slowing down the process through R&D. And that is really, as I say, is looking to, replicate and confirm the results of the phase 2 study. That was published in 2016, and that's being led by Emily Henderson in Bristol. So again, this is the next focus, I think, for the team in terms of recruiting into this. We're probably hoping to recruit around about 10 people or so locally, depending upon how we get on. Inclusion criteria: anyone with Parkinson's disease, Hohen's ER stage 1 to 4 is a pretty broad entry bracket. Basically, you have to have fallen once in the past year and able to walk more than 10 meters unaided. So the key thing there is, have you had a fall in the last year? You cannot take part, and again, the exclusion criteria are someone who's already prescribed a cholinesterase inhibitor, and that would be for dementia associated with Parkinson's disease, or they're not able to put the patch on every day or participate in the assessments. And part of the participating assessments is a lot of these are cognitive assessments, and therefore, if English, if you can't speak English, that does exclude you, I'm afraid, from this study. And again, if someone is falling more than 4 times per day, they can't take part. And again, the rationale for that is that the study assessments involve people getting up, walking, balancing on one foot, balancing on the other foot, all things that are actually more likely to make you fall over. So that would lead to potential harm. Contraception, so that's for younger people, male and female, who are not prepared to either abstain or have contraception. But again, it's pretty unlikely that someone is going to be that young and falling over. This is David Breen's study, the probiotic study. That's also going to open up probably late spring. David, I know, has already spoken to yourselves about this. That's twinned with the Stavanger site in Norway. So obviously we're quite excited about that. Again, excuse me, will be a very straightforward study to do. It's always, as I say, it's the entry criteria have to be pretty strict on to make sure that you're not then sort of causing anyone any harm. I'll skip over that. I'm just aware of time, and I'm probably spoken for far too long. Top Hat is a study, again, being run through UCL. This is looking at the use of ondansetron, which is actually historically an antiemetic and anti-sickness medication, as to whether or not that can help people with hallucinations. I'll skip through these slides quite quickly, given time. Cobalt, similar study actually, but it's being run through Newcastle. It's a multi-center study looking at the addition of memantine to either, well, principally donepezil or rivastigmine for people with Parkinson's disease or dementia with Lewy bodies, to see if it can improve someone's cognitive function and try and improve their neuropsychiatric symptoms. It's unlikely that we'll be involved in this one before summer 2023. Our opening sequence is going to be Chief PD, the probiotic study, Top Hat, and then this one. So I will come back to you in a few months' time and give you more information. I just wanted to give you a sort of a flavour of what was up and coming. Again, just in the interest of time, I will skip over that because I'm aware I have talked on too long. I'm sorry. So more information currently is via the NDN Lothian team. Phone numbers are there, email, we've got the website. We're always very happy to come and speak to the group. Hopefully next time I speak to you, I will not have a cough. Very happy to take any questions.
Thanks, Gordon. Could you stop sharing your screen? Thank you. So what we'll do now is we'll take a 5-minute comfort break, let Gordon have a good cough, and let me go to the loo. And we'll be back at 11 o'clock for some question and answers. And I'll stop the recording now.